Thank you, Ajay. So, this is my disclaimer and the financial disclosure. Today, everyone thinks anti-VEGF agents are a panacea, almost for all retinal disorders. Then when somebody says, well, this is a microangiopathy, say like diabetes, so wow, this is something for all cases of diabetic retinopathy, maybe anti-VEGF agents may have a role. Too simplistic, isn't it? Absolutely. Diabetic retinopathy is a continuum. It goes all the way from preclinical stage to advanced end-stage diabetic eye disease. So when all can you use anti-VEGF agents, and what should you do for the rest of the patients is something which we will see now. So obviously, if you have if you start looking at the treatment points in diabetic retinopathy, the first stage is no retinopathy or early NPDR, and it stands to reason that medical treatment is probably the best way to go for this. For patients who have diabetic maculopathy, proliferative diabetic retinopathy, or sequelae of proliferative diabetic retinopathy like vitreous hemorrhage, obviously there is a need for active ocular management. I must first stress on the fact that that medical control is not just for the sake of speaking. Medical control is something extremely important, and you can get very good control, a very good effect on diabetic maculopathy by controlling diabetes. And these are two slides from a friend of mine, Dr. Vatsal Parekh from Mumbai, and he shows how even patients who were only managed on good medical control, the maculopathy also started improving over time. So this is an essential part of the treatment for moderate to severe diabetic retinopathy as well as maculopathy. The issues for maculopathy are, well, is laser obsolete now? And if anti-VEGFs, which to use when? And if you want steroids, then when should you change? Let's go through some of this. There is this impression going around that laser is deleterious for diabetic maculopathy. And people quote to the poorer results as compared to the deferred laser group in RESTORE and DRCR. There are two fallacies over here. First thing is, they are considering that center involving macular edema is only having leaks within the macula. They don't. Center involving macular edema can have leaks which are more than 500 microns from the foveal center. And thus they may be amenable to focal macular laser. And both in protocol I and DRCR net, almost 50% of patients did have such lesions. So this is important. The second thing is, this is the slide based on which people are saying, oh, well, the deferred laser group does better than the prompt laser group. And if you look into the subgroup analysis, you find there is no difference between the laser group and the deferred laser group if you take only focal laser. When you talk of grid laser, diffuse diabetic macular edema, yes, the results fall, the results drop. So it is grid which is the worsening agent, not the laser per se. And that is what you must keep in mind. Focal laser does not compromise visual outcome. Now, to use anti-VEGFs for DME, my OCT is the initial part of the workup. We use anti-VEGF treatment to decrease the severity of the edema. And then before we do focal macular laser, we do a fluorescein angiography, and we laser all spots more than 750 micron from the foveal center. And subsequently, we give anti-VEGF agents as required. This is an example of a patient with multiple focal leaks, some within 750 micron of the foveal center and some further away. So you give an anti-VEGF agent, bring down the edema, then do the laser. Then after you've done the laser, you go ahead and give anti-VEGF agents for any further edema that may be left. The question about which agent to use when. So if the patient's vision is better than 618, makes no difference which drug you're using, and the gold standard I would still use as ranibizumab. For patients with a vision less than 618, initially aflibercept would be a good choice, followed by ranibizumab for maintenance. or ranibizumab as required. Now, the question is, why not bevacizumab as the preferred choice? We'll come to that later. Why aflibercept is coming from the point that those with poorer vision did better with aflibercept as compared to ranibizumab. But over a period of 2 years, that difference does become muted. So there's not so much of a difference with either of these two drugs. But if you see bevacizumab versus the other two drugs, the drying is much less with bevacizumab as compared to ranibizumab and aflibercept, and which is why I prefer to give ranibizumab as my drug of choice or aflibercept. There is no emergency. You can wait for up to a month or two, because you see over here, even waiting for 12 months and starting PRN after that, the treatment did come to the same point. So that's not the outcome came to the same point. So as initial treatment, how do you manage if the patient has got very good, if the patient's near vision is very good, distant vision is very good? I would not treat. And protocol V has confirmed that. You won't give them any advantage, and many of them will get up to 8-9 injections in the process. If the near and distant vision are affected, or one of them is affected, I would definitely treat these patients with anti-VEGF agents. And the treatment is given PRN from initiation till you get a control of the foveal contour and visual acuity. Now, when do you give steroids? Only if the patient's vision does not improve, or the OCT doesn't improve, with 2 consecutive injections or 3 consecutive OCTs are stable. Remember, anti-VEGF agents per se, just ranibizumab is the best biomarker by far. You see over here, if patients do not need an injection at month 3 and month 4 after receiving the first injection the first 3 months, these patients will not require more than an average of 4 injections in the whole year. And these are the patients who have a very good prognosis. On the other hand, the patients who don't do well, they're 20% who require injections every month for 2 years, and these are the ones where we don't do this, we will shift to steroids. If you have a patient who's not responding to anti-VEGFs, steroid and injection of Ozurdex can make all the difference. As you see here, 1 injection and you broke through the defenses, and this can then help you to get a response. In proliferative diabetic retinopathy, the issue of lasers, anti-VEGFs, or maybe both. So, well, if you give anti-VEGFs or steroids in combination with laser, you can decrease the macular edema and get better visual outcomes. So, how do I use anti-VEGFs in PDR? I will just come to that. First of all, the protocol S showed that the main difference was actually in the fields. And actually, if you see this difference, these are the peripheral fields. If you see, was in other studies which have done, they found 88% of patients post-laser PRP can pass their driving test. So it's not as if it's such a big problem. Now, what did anti-VEGF agents achieve with monotherapy? In patients without DME in the protocol S trial, 7 injections were needed in the first year, 10 in the second year. And in those with DME, 9 in the first year, 14 in the second year. But the number of injections came down in those who had PRP. Keep that in mind. So how would I prefer to treat these patients? Proliferative diabetic retinopathy with maculopathy, if the neovascularization is raised, complete the laser first and the anti-VEGF agents later. If it's a flat neovascularization, I would go ahead with a laser soon after an anti-VEGF drug. And if there are patients with NVE persistent after adequate laser, I would go ahead and give anti-VEGF agents. What is the role of monotherapy? We'll come to that. But as you can see from this, I prefer a combination of PRP with anti-VEGF agents as the optimal approach. And many studies have documented that this is the best way to go. For monotherapy, I will only give it if the patient is counseled. You may need 14 or more injections in 2 years. You need to come for a regular follow-up. If you don't come for follow-up, you could actually land up with traction retinal detachments, which require surgery or vitreous hemorrhage. You could end up without addition of PRP. These number of injections will increase significantly, especially if there's macular edema. In fact, it's seen that if you have macular edema and you give PRP, the number of injections for macular edema also go down. So keep that in mind. Monotherapy with anti-VEGFs is like catching a tiger by the tail. Don't do it. Don't take it lightly. Do it only after complete counseling. Otherwise, you may end up in trouble if your patients don't come for follow-up. I don't give anti-VEGF agents in patients with vitreous hemorrhage as a primary therapy, but I may give it preceding a surgical intervention 2 to 4 days before surgery, or in completely lasered eyes if there's a recurrent bleed, again with counseling, that if traction increases, you may need surgery. Ladies and gentlemen, judicious use of anti-VEGF agents as part of a multi-pronged attack is definitely helpful to preserve and improve vision in patients with diabetic retinopathy, and we can possibly maintain that vision in almost indefinitely if we go the right way. Thank you very much.